For those that don't know me, I'm Mark Germer. I'm the Division Chief for Otolaryngology, and I have the pleasure to introduce Richard Law this morning. Richard is one of our otolaryngologists here at Phoenix Children's, joined us 2 years ago, coming out of the Children's Hospital of Philadelphia Fellowship after doing residency in Detroit at Henry Ford. He has been a wonderful addition to our team. He is one of our leaders of our complex sleep, and is also doing a lot of work with anterior skull-based work. So he's going to talk to us today a little bit about sinusitis and management and skull base here at Phoenix Children's. So Dr. Law, all yours.
Hi, everyone. I'm Richard Law. I joined in fall of 2023 after fellowship. So today we're just going to be talking about a pretty common thing we see in this complication of pediatric sinusitis. We get consulted a lot on this, especially during flu season. I have no disclosures. And today we're just going to briefly review some sinonasal embryology and anatomy just for some of residents and fellows to get a good sense of what the sinuses look like. And then we're going to focus on some topics mostly regarding intraorbital and intracranial complications, acute sinusitis. We're going to discuss surgical and medical management, and then we're going to review a interesting case at the end. I'm not going to belabor embryology, but it's just, I feel like it's interesting to know, but sinuses and turbinates develop in utero at about 8 weeks. So there's these structures called the ethmoturbinals. I won't belabor all of them, but there's the first one that develops the Agernazian process. So the Agernazi, it's a very fancy name for the first ethmoid cell, the most anterior ethmoid cell. See it butts the frontal beam right here. And then the unsnip process is this curvilinear structure that really covers the or obscures your view of the maxillary sinus os. Usually you take that down as part of the first step of the maxillary, as part of your maxillary ostomy. And then it's pretty logical. The second, third, and fourth become the middle superior and supreme turbinates. I would say 90% of patients do not have a and on a CT scan, you can see here's the inferior turbinate. Can you see the arrow? Yeah. You can see this is the inferior turbinate. Then the middle turbinate is actually attached to the skull base. And further posteriorly on the scan, you'll see the superior turbinate. And I always describe to patients they kind of have stadium-like seating. As you go further back, they go higher. And sinuses develop sort of in a linear fashion. I'd say the sphenoid sinus develops at the 3rd month of gestation, but they're very small. And some newborns you'll see no sphenoid at all. And the maxillary sinus develops at about the 10th week of gestation, and they have a sort of biphasic. And ethmoid sinuses, usually kids are born with 3 to 4 cells, and then as we grow, start to see cells. The frontal sinuses are the last to develop. Start to see them at 5, 6, and they can have variable pneumatization. When I say pneumatization, is like some kids with chronic disease, such as cystic fibrosis, primary ciliary dyskinesia, they may never develop. There are some adults out there who have, which makes my life. This is just an example of the variable pneumatization of the sphenoid sinus. You can see here, this patient has no sphenoid. There's a tiny one here. It's called precellar because here's the cella where the pituitary gland lies. And then cellar meaning as pneumatized kind of right under the cella, and then post-cellar meaning it's gone even in the sphenoid process. These are pretty cool. And just to review the anatomy, when you use an endoscope just to go in, the first thing you'll probably see is the inferior turbinate. Then farther back, you'll see the middle turbinate. And just for reference, this is the right nasal cavity. So the septum is here on the right side of this. And the uncinate process, as I mentioned, will be kind of the first structure that you'll take down for your maxillary process. And the importance of this M line is I see a lot of residents try to take this down into the uncinate process, and right behind the M line is your nasolacrimal system. So I always double check, are you removing the right structure? And sometimes residents like to go for that because that's the first thing they see. And an interesting tidbit at the bottom, if you see a maxillary ostium with a 0-degree scope, it's probably an accessory ostium because the true ostium is usually hidden behind the uncinate process. So if you do see one, it's probably an accessory. And again, just to reiterate, the M line kind of highlights, here's the beginnings of the lacrimal sac. The ostium, the true ostium, kind of hides behind. I won't belabor this too much, but everything in sinus surgery is boundaries. Once you take down, I always describe to patients and their family that sinuses are little air cells separated by thin bony partitions. And when you remove all these thin bony partitions, you're left with very rigid boundaries, or not necessarily all of them are rigid, but when you remove the uncinate process and all the mucosa associated with the maxillary antrum, anteriorly will be the nasolacrimal duct. Remember that M line. So you do not want to go farther than the M line once you take down the uncinate. And posteriorly makes sense, posterior maxillary wall. And then superiorly would be the orbital roof or orbital floor, or the roof of the maxillary sinus. And then inferiorly is actually the insertion of turbinate. And you should end up at the end with a wide introstomy that looks kind of pear-shaped. Usually I use a 70-degree scope to look at the end, and it should kind of look, I know, I did not, you see it all over the papers and textbook. I don't think it looks like a pear, but they call it a pear. And this is a left maxillary enterostomy at this circle of this little white circle represents the anterior corner. And regarding the anterior ethmoidectomy, if you remove all the little bony partitions, you're left with the middle turbinate on its medial aspect, and then laterally is the orbit, which is the lamina propria. And then posteriorly it will be the basal lamella, which is part of the oblique portion of the turbinate that separates the anterior ethmoid. And then superiorly would be the frontal region. And the posterior boundaries of the posterior ethmoids would be the medial boundary being the superior turbinate, the lateral boundary being lamina propria, which is again bone separating the orbit from the sinuses. And posteriorly will be the sphenoid sinus wall, base of it, and then superiorly would be or the fovea ethmoidalis. And most commonly, if you do sinus surgery, the injuries occur at the skull base and at the also failing to recognize as you go posteriorly in a sinus surgery, the skull base starts to slope. So this is a view of after we took down the maxillary or create your maxillary necrostomy. This is the superior turbinate. This is part of the middle turbinate that's left over after the anterior ethmoidectomy. This is the basal lamella. That's what separates the anterior and posterior ethmoid. So some people will eventually take this down, but once you get to the sphenoid sinus, you want to take the superior turbinate, just the inferior third off, or to get to the I'm not going to talk about the anatomy of how to find the sphenoid ostium, but once you open the sphenoid sinus, you should have this very wide opening with a good view of the sella. and the optic nerve impression, and also the intracarotid artery impression. Some patients may not have a very well-defined optical carotid recess, but that's just the beginnings of the clinoid process. Sometimes it's not pneumatized, so it's variable in patients. So after you're done with a complete sinus surgery, you should see the maxillary sinus is nice and open. This is the lamina propria, or the medial orbital wall, skull base, and then this is the sphenoid sinus. Superior turbinate, part of the inferior third has been cut. This is the horizontal process turbinate, and the vertical portion of the middle turbinate. This is about 3 months out from surgery. You can see it's well mucosalized. There's maybe a hint of inflammatory tissue here and some crust there, but everything's wide open. And I'm not going to talk too much about the frontal sinus anatomy, but basically the frontal sinus is after you take down the ethmoids. Again, variable pneumatization in adults. For kids, they're usually pretty small. So just to talk a little bit about draft procedures, I'm not going to belabor it since it's mostly for us to worry about. So draft 1 is just taking down all the anterior ethmoids, and draft 2A is taking down all the frontal recess cells. And draft 2B involves partially resecting the vertical portion of the middle turbinate up to the floor of the frontal sinus. And then draft 2C is basically you're doing a one-sided draft 2B and then taking down the inner sinus septum, which is the septum that separates the left and right sinus. And draft 3 is one of my most favorite procedures. You're actually removing part of the anterior superior septum and connecting all the frontal sinuses, part of the nasal cavity. So this is a picture of a draft 2A. You can see the middle turbinate is preserved, and you took down all the frontal recess cells. You can see here skull base. That's the posterior aspect of frontal sinus, the nasal frontal beak, lamina propria, and then interestingly here you can see the anterior ethmoid artery. This is also a very important in your CT scan, because if it's not bony covered and it's low lying, you may accidentally injure it during sinus surgery, get blood all over the place, and if it retracts into the orbit, you get an orbital hematoma. Really. And then draft 2B is, as I mentioned, you take down part of the middle turbinate, the vertical portion, up into the frontal side. And then there's a paper that, well, I wrote when I was a resident. Some people argue that resect the middle turbinate, they can cause empty nose syndrome, which is a paradoxical sensation of nasal obstruction by the cavity, because they think they're nerve endings on these turbinates that regulate sensation of airflow. Some patients develop what we call empty nose, but we think maybe there's a psychiatric. So here's a view of the draft 3 cavity. You can see the inner frontal, the inner sinus septum has been taken down, but also the superior septum. You get this nice horseshoe shape. Then right behind it is the cribriform, the beginnings of the cribriform plate. So it's a very challenging procedure because there's a high rate of skull basing, not careful. So that's sort of the intro of anatomy and what sinus surgery entails. But let's talk about some of the complications that we can see in pediatric patients who get acute sinusitis. So the two most common complications is orbital extension. So for the orbital complications, we like to talk about Chandler classification, which you may have heard of, and is divided into 5 different classes. So class 1 is preseptocellulitis. 2 would be orbital cellulitis. 3 would be a subperiosteal abscess, and then 4 will be an orbital abscess. And 5 is cavernous sinus, which you can see on MRI. For class 1, usually their eyelids are pretty swollen. So It can look pretty remarkable, but that's why most of the time when they show up in the scan to develop it, to determine if it's preseptal or postseptal. And usually they, when you part their eyelids, if you try really hard and usually they're not cooperative for young kids, but you can have someone help hold them down. I know, sucks, but gotta do it. They usually don't have gaze restriction because it's all preseptal, and they usually have no chemo. For orbital cellulitis, there's no well-defined abscess within orbital cavity, but they can have some proptosis from sort of a mass effect from the edema. They may have some gaze restriction and some pain with eye movement. And they can have some diplopia if pretty severe. Again, for very young kids, they can't tell you double vision, but for older kids, they can tell you, yeah, you hold up one finger, it looks kind of blurry and being two instead of one. Usually for the first two classes, don't surgery because abscess. They're treated with IV antibiotics and plus or minus systemic steroids. And we can talk a little bit more about the controversy about using steroids. Ophthalmology consult for more severe cases. And that's very institution dependent. Some places, they always get ophthalmology. Here, not necessary. It's not always necessary. And you just want to keep a close eye on them when they're on IV antibiotics, steroids. And if they do not improve or their exam worsens over time, you should get a repeat CT scan with contrast to see if they developed an regarding steroids, so there's not a whole lot of evidence supporting or going against steroids for these non-surgical treatments. And even more controversial is the dosing. No one really knows what the dose is and how long do you give it to them. And this one paper, they talk about giving a high dose, 1 mg per K dose for 3 days, followed by a lower dose for another 3 days. And the thought and rationale behind giving steroids and non-surgical treatment for Chandler class 1 and 2 is that you are decreasing edema in the cavity and you are allowing the natural ostium to drain whatever inflammation or pus that's in the sinus cavity. So in conclusion, there's really no evidence supporting going against steroids. And as I mentioned, there's a significant variation in use, especially at different institutions. At CHOP, they usually don't want us to give steroids, but I always recommend some steroids if you're not doing. Interesting enough, steroids only address symptoms in terms of the eye swelling and some of the pain with eye movement. And in this paper, they said there's actually no difference in length of stay for a hospital stay compared to just antibiotics. So I think for what it's worth, steroids, it's up to you, but I think it's worth a try if you're not going to do not going to do surgery to kind of open up the natural ostium outflow. Regarding nasal sprays like oxymetazoline or Afrin, Flonase, or saline sprays, that's even more controversial. Here we always recommend, and it's very institution dependent. Here we always recommend nasal spray because why not? The risk of it is pretty low. At CHOP, we would never, ever give nasal sprays because for younger kids, especially under the age of 6, they're not going to be very cooperative. You're not really sure how much it's actually getting anyway. So I would say in older kids, yeah, why not? Give it a shot. I think it's worth it. But again, there's no robust data to suggest using it or not using it. For the next two Chandler classification, which is subperiosteal abscess and orbital abscess, usually we get ophthalmology consult. Again, it's also very institutional. At CHOP, we had resident fellows. They go to intraocular pressures. Here, not necessarily. If you think that you're going to take them to surgery to decompress them anyways. So how useful is to get in preoperative ocular pressure? But sometimes they do them in the ED here, but depends. So usually these require surgical intervention, and then I'll talk very briefly about some studies that show you don't always have to intervene on very, very small subperiosteal abscesses, but the data is still a little bit fuzzy about who would be a good candidate and who. And regarding steroids for observing small subperiosteal abscess, again, I prefer not to give steroids if there's an abscess there already. I'd rather not mask some of the symptoms that can hint to me that there's progression. So here's a paper that everyone quotes. It's actually in the American Academy of Ophthalmology. They keep saying, like, who would be a good candidate, a non-surgical candidate, and what are the likelihoods that they're not. So they talked about kids less than the age of 9 with orbital subperiosteal abscess can likely resolve without surgery. It's a very arbitrary cutoff. It's a very old study. It's a single institution study with only a few patients. So I don't know why people keep quoting this paper, but I would say most kids that are under the age of 9 with an abscess often go to surgery. So if you ever see this paper, a lot of people do reference it. And this is the paper I was talking about regarding volumetric studies on CAT scan. So this paper talked about kids with orbital with an abscess volume of greater than 500 cubic millimeters tend to get surgery, whereas less than that, they may not need surgery. It's very hard to measure this because most of these abscesses are not perfectly round in shape. They're usually long and thin. And so it's really hard to calculate the actual volume. I would say if there is a subperiosteal abscess and you think it's going to, if they're antibiotic naive, it's worth trying IV antibiotics for 24 to 48 hours. And if they do not resolve, you should probably take them. Probably take them to surgery. Do sinus surgery and do a wall compression. Ultimately, again, for these small subperiosteal abscesses, if they start to have visual acuity issues or changes in pressure, you should probably just take it. And then for non-medial subperiosteal orbital abscesses, so most of these are direct extension from the ethmoid sinus. This is right next to the eyeball. But sometimes there's a hematogenous spread through these veins. The veins in your face have no valves, so they can go retrograde. So sometimes you'll see abscesses in the orbital cavity that are nowhere near any of the sinuses, and these are called non-subperiosteal orbital abscesses. And you can't really drain it through the sinuses because there's no direct connection. So I always have to ask my oculoplastics colleagues to help out. Sometimes they'll do an upper lid incision or a brow incision to get to the abscess. So this is one example. You can see it's way up here, but I can take down all these ethmoid sinuses, but I'm not going to go through all these muscles and veins, potentially injury for the optic nerve or ophthalmic artery just to get to this eye. So I'd rather do a brow incision, just get to the superior orbital abscess. So sinus surgery can't fix everything. So there's a paper from CHOP about if there's a non-medial subperiosteal abscess, do you really need to do sinus surgery after you've have oculoplastics drained? Because the cultures from that abscess match the likely the cultures sinus. So they kind of argue, kind of playing the devil's advocate. Do you really need to drain it? I would say there's not enough evidence to suggest that we the sinuses alone. I'm all about source control, so I'm a pretty conservative surgeon. So if you have hematogenous spread and there's a source, I would probably want to do source. So I would almost always want to just open this. Again, the data is fuzzy and limited. So some places they may not necessarily want to do a full sinus. Again, like I said, in the meantime, you should consider endoscopic sinus surgery for non-periosteal abscess. And the last classification would be cavernous sinus thrombosis. As you know, the cavernous sinus has many structures within it, including the carotid artery, all the nerves to the eye for ocular movement, and the E1 and V2 distribution of trigeminal. If they have cavernous sinus thrombosis, I would say it's considered intracranial. I would operate on them on. Again, it's all about source control. You want to remove source of the infection and the inflammation that's causing thrombophlebitis. What about anticoagulation? So the data regarding anticoagulation for cavernous sinus thrombosis, this is I would say the most quoted paper that most academic institutions use. There's no great data. Most of these are single institution studies. There isn't really a multi-center study regarding this. I usually just leave it up to neurology or infectious disease to anticoagulate at CHOP. They're very aggressive. They almost always anticoagulate kids. Here it's kind of 50-50. It just depends on who's service. But again, there isn't really any great data on. Let's talk about the next complication, which is intracranial extension. The most common ones you'll see are epidural abscess, subdural empyema, and then there's a variation of all that. It's Pott's puffy tumor, which is a misnomer. It's actually just frontal bone osteomyelitis because the infection has gotten so bad. It's also infiltrated the vessels in the frontal bone, and you'll see swelling of the forehead. Sometimes there's a subperiosteal abscess. Instead of within the sinus cavity, it's actually. And subdural empyema is bad. Usually it's associated with repeat intervention. So it's a very different beast than epidural abscesses. And usually the bugs that grow out from these subdural empyemas is strep anginosus group, most likely strep. So if you've ever been on service and we do one of these, I'd say pretty commonly is strep anginosus. And these kids can show up with abnormal neurological exam. Usually some kids can be a little obtunded, some may have nerve deficits, and some may just come in full-blown seizure. And I've had a few kids where they come in, they're okay, but then overnight they develop seizures. And you need to perform sinus surgery on all of them? I say yes. Intracranial extension, you should. Usually the frontal sinus is involved in infections. Even for younger kids, their frontal sinuses may not be fully developed, but you can probably still get a little bit of pus out from whatever frontal sinus. This is what was quoted in one of the papers. About 46% of these kids with subdural empyema go back for revision surgery, or because the infection is so recalcitrant, they may need drainage. Here's a brief video of a kid I had on call a couple of months ago with Pott's puffy tumor. This is actually the left frontal sinus. You can see some pus coming out. It's quite rewarding when you get to the pus. On the right side, this is actually the right side. It was pretty clear on the right side, but the left side had quite a bit of pus. You can see I drained most of the pus, but you can see some thick mucus there. And then I flushed it out. Usually after you open all the sinuses, you want to flush out with some warm saline to get everything out. Kind of see it, get a good view of the front. I'm just kind of picking away at things. So here is actually the posterior table, meaning that skull base, and this is the anterior table, and that's just the top of the frontal sinus. The bone is quite abnormal. You can see it's kind of whitish. I mean, bone is white, but it's also infiltrated with some pus. So this is some signs of osteomyelitis. And the kid's exam for when he first presented was he had forehead swelling. We all thought he had an abscess there. It was just an edema, so we kind of caught it early. But these can develop abscesses. How do you drain it cosmetically? Sometimes I put a needle in there, decompress it or if it's pretty bad, I might make a little incision by the brow and put a small drain there. But you never want to just make an incision in the forehead. It's not cosmetically. But if you put it in a wrinkle, which most kids don't have wrinkles, it can look pretty pleasing. In adults, older adults, if they have a very deep wrinkle there, it happens, I put it in there. I don't treat adults anymore. So that's just a more view of the frontal sinus after. I think this was my December Thanksgiving. Oh, yes. And here's another paper coming out of CHOP regarding, do you really need to drain the frontal sinus if, say, neurosurgery is doing a frontal cranialization? So at CHOP, I learned that they're very aggressive, the neurosurgeons. They cranialize about 70%. So if you cranialize, which is meaning you take down the posterior table of the frontal sinus and let the brain kind of come forward, just put a pericranial flap to separate the nasal cavity sinuses after you drain the abscess. You don't really need to do a frontal sinus surgery, but here, again, it's very institution dependent. We don't cranialize as much at PCH, but I will always do a frontal surgery. But if they're cranializing, I probably leave it alone. And there's the data regarding, do you need to open up all the other sinuses after a frontal cranialization? Again, you source control, open up the maxillary sinus, ethmoids. That's still up for debate. Some data suggests you don't have to. Again, I'm a little conservative, but I'll go ahead and open up the max. But there is data that support you don't necessarily have to open up. I do want to go over a case with you. This is an interesting one. This came in over the summer. It's a 14-year-old male with obesity who presented to the ED with a left eye swelling in the last 2 days. Some of his symptoms include nasal congestion, right greater than left. Parents mentioned he had URI symptoms and right low grade 2 weeks ago. So it's believed that maybe he has an acute URI that caused him to have acute left eye swelling. And he has never tried outpatient antibiotics, and he has no prior sinus surgeries or any surgeries. Interestingly, on his physical exam, he has left periorbital edema, and his right eye is normal. And for all these cases that come in with concerns for complication of or intraorbital complication of acute sinusitis, you always want to check their pupillary. So his pupillary responses are normal. He has mild gaze restriction medially, but all of his cranial nerves are intact. And he has a lot of nasal inflammation when we take a peek in his nose. And in his left nasal cavity, we weren't sure if it's a polyp or a mass or just a lot of inflammation. We didn't scope him at bedside yet, but we did later. And it's most notable is his left hypertelorism, which it was kind of weird because I asked the parents and the patient, like, your left eye is really, really displaced to the left side. How long has this been going on? They're like, oh, they seemed very not concerned about it. So he was started on broad spectrum antibiotics and without a CT scan. His lab shows elevated white count and he has a low. So on CAT scan, you can see here's the frontal recess cells. You can see his eyeballs. His proptosis is pushed over to the left side, but you can see it's broken through the bone, and you can probably see beginnings of an abscess. But oh wait, what is that? There's a whole chunk of bone here that's not normal. It's like having a piece of femur in your sinus. That's really not normal. So this case was interesting. So we got a stat MRI, and it shows there's this, well, we got an MRI afterwards, but on the coronal view, you can see the big bony lesion protruding into the medial orbital cavity. Here's another view of it. So we get an MRI. We actually have ophthalmology to do an intraocular pressure. They were normal. So it was likely an acute on chronic process. So he developed an abscess on top of this mass that he's probably had for the last 6 months. So on MRI, this is a MRI bone is black. So you can see that thick bone at the bottom. Here is this kind of spongy bone superiorly, but you can see there's the abscess right here on the medial aspect of the cavity. Here's another view on MRI of this bony lesion. So it turns out that he has fibrous dysplasia, which is a benign growth, bony growth. So as you can see, it has thick bone here, but that spongy fibrous bone. So we go in his nose and we see this ginormous mass here, and you're like, how am I ever going to get there to drain it? So, well, obviously you got to do some drilling. So we were able to, so a 1 hour procedure usually takes about an hour to drain these, became a 3 hour procedure. So first thing first is take a biopsy. It looks like fibrous dysplasia, but you want to rule out other bony lesions. So you take a biopsy. You can see I'm only ripping mucosa. At some point, I take a whole chunk of bone and send it off. But you got to drill. So this actually took forever because the bone was so dense. It took about 2 hours to get to where we need to get to. You can see the beginnings of that fibrous spongy bone in the back. So the dense bone is not very bloody, but for fibrous dysplasia, the bone gets pretty spongy and has a lot of venous channels in it, so it bleeds like stink, and you have to use suction cautery. Here we're just digging out a trough of the bone here, and then gotta take I freed up a small piece there that we sent off pathology. It came back as, but here's a whole chunk of bone. But now he can finally breathe, right? Before he couldn't breathe at all, and it's again very disturbing that it's had nasal obstruction for over 6 months, and they only just came in with this swelling. So we were drilling. I don't want to bore you with more drilling, but eventually we get to the abscess. I was very concerned because if you saw the scan, it was actually going to skull base as well, and I didn't want to CSF leak. So the worst thing you can do is cause a CSF leak. Fixable, but very annoying when you have all this fibrous dysplasia. So you can see the beginnings of a little bit of pus there, right there. And so we got to it, and then my resident is pushing on the eye externally. So usually the bone here is pretty soft, and as you're pushing on the eye, more pus starts to come out. It's not like a very satisfying gush of pus because some of it had already decompressed as we were drilling. I see my residents pushing on the eye, and there's some pus coming out right here. So eventually we got all the pus out. And he never showed up for follow-up, which is very upsetting. But we called him a few times. The thing is, he didn't want surgery at all. Like when we had to convince him that this is going to be a real problem. It can go to your brain. And then finally he said, yes, okay, I'll do surgery. And the reason was both his mom and maternal grandmother passed away from surgical complications. We don't know what. They could not explain why. And he was scared to death. I get it. Like if both your mom and grandma passed away on the table, like you would freak out too. So it took him took a lot of convincing to get him on the table. And then he probably never wanted to see me back because I said, oh, well, we may have to do more surgery to remove a little bit more of the fibrous dysplasia. Probably why he did back, but we will try again. So I'm pretty persistent. So I'll have to call him again. By the way, the kid with the POTS puffy tumor, I'm seeing him right after this. This is so that's a interesting case I want to review. So you can have acute on chronic process. That was a pretty. Thank you for your attention. If you have any questions,
What are you guys?
I would say if it comes overnight and they have an abscess, as long as there's no concerns for like a visual acuity issues, because if you have increase in pressure, you probably have visual acuity changes. Those are you have to take that night. If they don't, you can probably wait. Same thing for intracranial complications. Usually, I'm more inclined for intracranial complication to take them back before they develop a seizure. So, if I'm a little more worried about intracranial than intracranial complications.
Yeah, it's a wonderful talk. You want to speak a little bit about some of the things we're seeing post-COVID with increase in strep, increased aggressiveness?
Yeah, in terms of post-COVID, and I've been seeing more aggressive cases. Some of them, like I would say in residency, I actually had a case where I thought I could just sit on it, but ends up that kid had progression, and then we had to take him to surgery a few days later. Actually, one of my Boston, but after the whole COVID pandemic, things have just been a lot more aggressive. I don't know if it's because of kids not being exposed to a lot of these viral illnesses or pathogens, and now they're pretty aggressive, especially for intracranial complications like strep intermedius, strep aneminosis group. It's a different beast. Say for most subdural empyemas, at least on call, about 50 to 60% going back to neurosurgery will do either burho or craniotomy to drain these abscesses. Sometimes they put a drain, and sometimes they don't. It depends on the size, but they can get.
It's impressive the difference that we've seen in the idea of source control. In my past life, I would be much more conservative. And I felt many of these kids just needed medical therapy. I have turned 180 degrees. Source control, I think, is very important and much quicker to go to the OR to get drainage. And these kids it's pus under pressure that's developing these complications.
Are they presenting later, you think?
I don't think so.
Is it different?
I just think I honestly think it's a more aggressive version. And we're seeing this on a national, international trend. This is not just local to Phoenix.
Right.
This is everywhere.
Yes.
A couple questions. First, do you routinely send cultures when you're draining the sinuses? Because that helps really guide our management.
I routinely send cultures. That's what we know what's growing, and if it's MRSA or something pretty resistant, at least. But yes, I usually. And if they've been on antibiotics, like outpatient for a while and it's slowly progress, sometimes it does. But you still want to just decompress them and, again, get some sort of source.
And my second question is, once someone's had a complication, orbital or intracranial, is your treatment of subsequent sinus involvement more aggressive in any way? Like if we were following them up on the other end, do you start treatment earlier? Do you I don't know, do anything differently, like nasal rinses or anything to try to decrease bacterial further sinusitis?
After, okay, usually it's I'd say most of the time for at least orbital cases, it's one and done. That's all they have, but once you take down the sinuses, that you have wide open drainage. So usually after surgery, if I do remove part of the medial orbital wall, I would probably not want to irrigate too much right away. But if I did need to take down a significant portion, yes, I would want to do some aggressive irrigation, especially for kids that are older and are compliant. For younger kids, if you try to ask parents to do nasal irrigation, like the high volume, like Neomed rinses, they probably won't like it, and parents probably don't want to deal with it. So, but yes, for older kids, I would say I'm aggressive with nasal irrigations.
Got one here from one of our ID docs. He says, thanks for the timely topic since we're in the middle of the respiratory season. A couple of reminders for everyone. One, make sure to follow the orbital cellulitis pathway and use the order set. Two, when developing the pathway in 2023, all the specialties involved, ID and ENT, ophthalmology, oculoplastics, hospital medicine, ED and radiology agreed that systemic steroids should not be routinely used. And three, anticoagulation is usually determined by hematology if considered. Then a question on my own, when you as a surgeon take down a lot of the sinuses and stuff, what are the long-term implications? I mean, like if you know, are people that live for 50 years after, you know, or whatever, you know, without having sinuses and turbinates and.
That's a good question. In terms of, or at least acute sinusitis, after you take down or open the sinuses, the sequela is pretty low. I mean, you can get scarring. When you open sinuses that's actively inflamed, there's a higher rate of developing scarring or contraction of the opening, and you may have to do revision sinus surgery. That's why I always follow them operatively. And then if it's an older kid, I will scope them and just make sure their sinuses are pretty open. In terms of removing turbinates, for smaller kids, if the access is an issue, partially removing the turbinate usually doesn't cause much issue. There's some data that suggests, because some of your olfactory nerve fibers actually go on the superior part of the middle turbinate. Some people think there's decreased sensation of smell. For little kids, they are very adaptable. So I'm only removing like the lower third of it. So it usually doesn't impact their olfactory outcome. Usually never really. So that's the problem with doing surgery on kids, is they can't really tell you that much. And I don't follow them necessarily for life. So I don't know if our teenager like, hey, I can't smell the smell. Is that a problem? So I'd say the complications of partially removing the turbinates and opening the sinus. But yes, about our orbital pathway, yes. But I am guilty of sometimes giving steroids. Sorry.
Thank you very much. Little snakes.
They're tough.
I guess I gotta do you guys do one day.